Arterial blood gas studies, or ABGs. The purpose of ABGs is to assess the ability of the lungs to provide adequate oxygen and remove carbon dioxide. It's also to assess the ability of the kidneys to reabsorb or excrete bicarbonate ions. This is to help maintain normal body pH, and also to assess lung damage after trauma. ABG analysis is the best way to determine the need for oxygen therapy for your patients. It's used to detect respiratory acidosis and alkalosis. Acidosis occurs when we retain CO2. These are your patients that are hypoventilating, like your COPD patients. And then alkalosis occurs when we hyperventilate. There's excess CO2 that's exhaled. This would be in the case of maybe somebody with anxiety or hysteria, and that's respiratory. And then bicarb, or HCO3, this represents most of the CO2 in the blood and is regulated by the kidneys. It is directly proportional to pH, so they both go up and down together. If your kidneys are excreting CO or HCO3 or bicarb, if they're excreting too much of it, your bicarb is going to be up, and so will your pH. And then that is considered alkalosis. And then if your kidneys are retaining that bicarb, your bicarb levels in your blood are going to be down, and so will your pH. Arterial blood draws are from radial, brachial, or femoral artery. And they can be through an indwelling arterial catheter. An ABG test can be painful. It's definitely uncomfortable. Typically, they're going to do it from both sides of their wrist. That's where I most commonly see that being done in the hospital. And typically, when a provider orders an ABG, they don't just order them on the whim, that there's something that possibly leads up to it, or they're trying to rule something out, but looking at that patient and the symptoms that are going on. Okay, so sometimes it can be a challenge reading ABGs. The best place to start is to know your normal values. So on this slide, you see the normal values there. They're fairly easy to remember. So for pH, the normal values are 7.35 to 7.45. If you take those last two numbers, your PaCO2 are 35 to 45, and then your bicarb is 22 to 26. Remember, PaCO2 is your respiratory and your bicarb is your metabolic. You can see that the numbers are intentionally inverted for the purpose of this slide here, because everything on the right is basic. So if you have a PaCO2, anything that's less than 35 is basic, and anything greater than 45 is acidic for your PaCO2. So that's why those numbers are inverted, to try to help you remember that a little bit easier. And then bicarb, acidic, less than 22 and greater than 26, and pH 7.35, less than that is acidic, and greater than 7.45 it would be alkaline. Okay, so next thing is to determine the acidity or alkalinity of the blood through the value of pH. The pH level of a healthy human should be between that 7.35 to 7.45. The human body is constantly striving to keep pH in balance. If the pH level drops below that 7.35, it's considered acidosis. And if that pH level increases above 7.45, it's alkalosis. Okay, next thing you need to determine is whether the acid base is respiratory or metabolic. So PaCO2, that is respiratory, and bicarb, or HCO3, is considered metabolic. ABGs, so remembering your ABGs. Now, I was taught how to remember ABGs by Rome, R-O-M-E. I do understand that people learn things differently, they absorb it differently. So I do have a YouTube video at the bottom of this screen that shows you the tic-tac-toe method for remembering ABGs. And I strongly suggest that whatever way it helps, whatever way you can do to help memorize this or learn these will greatly benefit you. So ROME the R stands for respiratory, the O stands for opposite. We'll look at that first. So respiratory opposite, what that means is the pH and the PaCO2 are always opposite. They're going the opposite direction. So when your pH is up, your PaCO2 is going to be down. And when that occurs, you have alkalosis. So respiratory alkalosis. When your pH is down, your PaCO2 is going to be up, which is respiratory acidosis. And then M and E, M is metabolic and E means equal. So what that means is your pH and your bicarb always go in the same direction. So if your pH is up, your bicarb is up, that's going to be alkalosis, so metabolic alkalosis. If your pH is down, your bicarb is down, that would be metabolic acidosis. So that's one way that you can remember these ABGs, but again, you can use the link to help as well. Okay, so I'd like you to try and solve this problem without looking ahead for the answer. So your pH is 7.26, PaCO2 is 32, and your bicarb is 18. What are we looking at here with these ABGs? Okay, so let's look at this. pH, a pH of 7.26, that is low, so that is acidic. You have a PaCO2 of 32, which is also low, but remember, low for respiratory is a base, not acidic. And then we have bicarb of 18. 18 is low, that also is acidic. So let's look and use that mnemonic ROME. So respiratory opposite of pH. They're not opposite, they're going in the same direction. They're both low. pH and bicarb, so metabolic equal. So both pH and bicarb are going in the same direction. So they match up. So this would be considered, they're both acidic, and so this would be metabolic for the bicarb and normal pH. So I just wanted to highlight this because I have had that question before, is what if their pH is 7.44? Where do I put that? Because it's considered normal. So a pH of 7.44 is still pushing in that basic. It's farther away from the acidic, so we say it's slightly basic. So it's slightly basic, so therefore it's still alkalosis. And then of course, if it was on the other end of the spectrum at 7.34, then it'd be slightly acidic. Okay, next we need to determine if ABGs are compensated, partially compensated, or uncompensated. So in our bodies, we need our pH to be normal, that 7.35 to that 7.45 range. CO2 and bicarb, they work together to help normalize a pH. So if you see that both of those bicarb and CO2 are abnormal and you have a normal pH, this is a compensated picture. So every time you look at your ABGs, if you see a pH that's normal, you should be thinking compensated, but then you need to look at that CO2 and bicarb. And if you see they're both abnormal, they're both working. So they are compensating for that. If a pH is abnormal, and you look at a CO2 and bicarb and both of them are abnormal, you have a partially compensated. So those two working together haven't quite got that pH into that normal range, but they're working on it. So it's partially compensated. And then if a pH is abnormal and a PaCO2 or a bicarb is abnormal, this is considered uncompensated. So it's not compensating. Whether your CO2 level is up or down, but your bicarb isn't doing anything to compensate it, it's in the normal range. It's not working to compensate, so it's uncompensated. You'll see a link on this page of a YouTube video, again, to help kind of get a better grip on this too as well. So you're really going to want to focus on this to make sure you have this down. Throat cultures. The purpose is to identify organisms responsible for pharyngitis, to identify organisms responsible for lower respiratory tract infections. Someone will come in with symptoms for strep, and you might see the physician order a rapid strep. However, they do have a 20% false negative rate. So if the symptoms are there, typically a culture is done. A culture procedure, the specimen is obtained from the tonsillar pillars and posterior pharyngeal wall with a sterile swab. Sputum studies. So the purpose is to identify pathogenic organisms, to determine whether malignant cells are present, to assess for hypersensitivity states, to assess for opportunistic infections for patients receiving long-term antibiotics, corticosteroids, or immunosuppressant medication therapy. The procedure for a sputum study is to instruct your patient to clear their nose and throat and then rinse their mouth. Instruct the patient to take deep breaths, then cough using that diaphragm and expectorate into that sterile container. And then you as the nurse need to get that sputum sample to the lab within 2 hours. Specimens from deep in lungs or the bases of the lungs, those are what we're looking for when we're collecting a sputum study. And then the best time to get a sputum is in the early morning. Not necessarily would we put it off, but if we can get an early morning sputum, that's the best. For pediatric, there's a variation. Young children and infants, we're going to do it like a nasal washing with them. Pulmonary function tests. These are non-invasive tests that show how well the lungs are working. The tests measure lung volume, capacity, rates of flow, and gas exchange. This information helps your healthcare provider diagnose and decide the treatment of certain lung disorders. Indications for a pulmonary function test would be to determine cause of dyspnea, screen at-risk patients for lung disease prior to them starting to have symptoms, monitor patients with established respiratory disease, assess response to certain therapies, determine extent of dysfunction, and then pre-surgical screening for patients undergoing thoracic and upper abdominal surgeries. Now for you as the nurse, some nursing interventions. Patient may be instructed to avoid heavy meals and smoking prior to the tests. They may be instructed to stop taking certain meds. Patients may be taught to use spirometer to measure peak flow. Spirometry with volume collecting device might be used. And then some tests, you can inform them, require you to breathe normal and quietly, and then others require forced inhalation and exhalation. So just kind of pre-warning them about what this test all is going to include and entail. Invasive diagnostic tests. So bronchoscopy, this is an examination of the larynx, trachea, bronchi with an endoscope. They may take tissue samples when they go down. This requires a signed consent, and the patient needs to be NPO for 6 hours prior to reduce the risk of aspiration due to that suppressed cough reflex from the anesthesia. They are going to use a topical anesthetic along with sedation. And then nursing interventions for this patient is post-op NPO until that cough reflex returns. And then of course you want to monitor their respiratory status. Thoracoscopy, this is endoscope through that chest wall. Again, as the nurse, you want to be monitoring that respiratory status after the procedure. Thoracentesis, this is aspiration of the pleural fluid or air from the pleural space. No more than 1,000 units are usually taken off at one time, and if there is, then we need to do some interventions with that. But that's typically what their goal is to not take off more than a liter. They're going to, if you want to talk to your patient about this procedure, you're going to explain to it as a stinging sensation and then feeling of pressure. And you want to make sure that you are putting your patient in the correct position when you're prepping them for this procedure. So if you bring a table or something that they can lean on, you can see in this picture, you want to encourage them or notify them that the most important thing is that the patient must remain motionless. And nursing interventions is you want to monitor for signs of a pneumothorax for the first 24 hours. If there is any question, they'll do a chest x-ray to confirm. You're going to monitor for respiratory distress syndrome. So this includes pain. Their heart rate becomes very tachy. They have rapid, shallow respirations. They have absent lung sounds. They will have deviated trachea to the unaffected side. They may be cyanotic and have a cough. Chest tube is possibly placed at this point in time. And then you want to check that site for bleeding and leaking after the procedure is done, and encourage deep breathing for lung expansion. Lung biopsies. This is an invasive procedure where they go in and obtain tissues for analysis, culture, and examination of those cells. This may be performed in the patient's room. Follow-up care includes assessing vital signs and breath sounds at least every 4 hours for the first 24 hours. You want to be assessing for respiratory distress or any signs of a pneumothorax. Report any reduced or absent breath sounds immediately and monitor for hemoptysis, any bleeding at that site, or any signs and symptoms of infection. The answer is D. The rationale is a person ages, vocal cords become slack, changing the quality and strength of the voice. The anterior-posterior diameter increases, respiratory muscle strength decreases, and the residual volume increases. The answer is B. The rationale: oxygen dissociates with the hemoglobin molecule based on the need for oxygen to perfuse tissues. Under normal conditions, 50% of hemoglobin molecules completely dissociate dissociate their oxygen molecules when blood perfuses tissues that have an oxygen tension or concentration of 26 meters of mercury. This is considered a normal point at which 50% of hemoglobin molecules are no longer saturated with oxygen. Answer here for question 3 is A. The rationale: cough is a main sign of lung disease. Dyspnea, or difficulty in breathing or breathlessness, is a subjective perception and varies among patients. A patient's feeling of dyspnea may not be consistent with the severity of the presenting problem. Sputum production may be associated with coughing and indicate an acute or chronic lung condition, and chest pain can occur with other health problems as well as lung problems. Why do we need oxygen? Oxygen is an essential body nutrient for life and function of our cells and tissues. The respiratory, cardiovascular, hematologic systems all work together to help provide sufficient tissue perfusion to the body. Oxygen therapy helps improve oxygenation and tissue perfusion. So the air that we breathe, room air, is 21% O2. What's the other percent? So we have 78% nitrogen, and then there's 1% of trace elements. So argon, CO2, there's neon, helium, methane. That's what that room air consists of. So 21% oxygen, 78% nitrogen, and then 1% of some trace elements. So terms to know: we have ischemia. This is an insufficient flow of blood to tissues. This might result in hypoxia, but just that there's not enough, there's something that's causing that insufficient blood flow to the tissues themselves. We have hypoxia, which is an insufficient oxygen that reaches the cells. This can cause the cells to die or injure the cells, causing necrosis. And then we have hypoxemia, and that is a low levels of oxygen in the blood, so less than 50 millimeters of mercury is considered hypoxemia. Okay, so oxygen therapy. The purpose of oxygen therapy is to relieve hypoxemia. However, the goal is you want to use the lowest fraction of inspired oxygen for acceptable blood oxygen level without causing harmful side effects. So you need to remember that oxygen is a drug as well as any of your other medications. So you want to use the lowest fraction for acceptable blood oxygen levels. The goal is to provide adequate transfer of O2 in blood while decreasing the work of breathing and stress on the heart. ABG analysis is the best way to determine the need for oxygen therapy. Hazards and complications of oxygen therapy. So combustion enhanced. It's definitely a fire hazard, so you want to keep away from any flame, cigarettes, candles, etc., and use grounded plugs to prevent electrical sparks while in the room. No frayed cords or increased concentration of alcohol. So these are things that you're going to want to be aware of when you're going into a patient's room. Sometimes you'll see that they're bringing in their own, maybe it's a fan or an extension cord for some of their electronics. Some people that are in, like your patients with cystic fibrosis, they're in sometimes for 2 weeks and they make their room their home, but we really need to be mindful of what's going on in that room as far as hazards are with that oxygen. Oxygen-induced hypoventilation, so carbia. That's the retention of CO2. Um, COPD patients were thought to all retain CO2, and it was feared that they would lose their hypoxic drive. This has been proven untrue for most COPD patients. Oxygen toxicity. It's a concentration level of O2 greater than 50% for more than 24 to 48 hours may injure the tissue integrity of the lungs, causing respiratory distress. So just like we had talked about that oxygen being a drug, you can have oxygen toxicity. For this, you're going to want to monitor ABGs and let the healthcare provider know if a PaO2 level becomes greater than 90%, it may need to we may need to decrease levels of O2 the patient is receiving. So we really want to keep an eye on those. Absorption atelectasis. This is a new onset of crackles and decreased breath sounds. Normal air we breathe in has 79% nitrogen, which helps maintain airways and alveoli. When we're increasing that O2, we're decreasing the amount of nitrogen, which causes the alveoli to collapse or causing atelectasis. So remember, normal oxygen in is 21%, but as we're increasing that oxygen, we're decreasing that nitrogen, and that nitrogen is what keeps our alveoli open and not collapse. So we want to make sure that we're monitoring for the new onset of crackles or decreased breath sounds. Drying of the mucous membranes. If you're using, if you have an O2 level greater than 4 liters, or if it's on continuous, you want to avoid mucous membranes from getting irritated or breaking down. So you want to be humidifying that air, adding that sterile water bottle onto your oxygen. And then you want to be monitoring for infection. So you want to really be monitoring that equipment. The nasal cannula tends to drop on the floor sometimes when they take it off, so that we're cleaning and we're avoiding things that could potentially cause infection. And then just monitoring for skin breakdown around the ears from the cannula, around the nose from a mask. I'm just really doing a good skin assessment when someone's getting oxygen therapy. Oxygen delivery systems. So the type used depends on certain things. Oxygen concentration, what's required, where do we want them, what do we want to achieve with the type of oxygen concentration. Kind of looking at your patient and seeing and adjusting as needed. The importance of accuracy and control of that oxygen concentration, monitoring that oxygen level. Comfort of the patient. So some patients can't handle a mask. So maybe utilizing something like a high flow nasal cannula, something that's going to give them a little bit more comfort. But they might feel more claustrophobic if that mask is on versus a nasal cannula. The importance of humidity, really watching those mucous membranes, making sure that they're not drying out. And then are we decreasing their mobility because of the oxygen, and what can we do to help with continually offering them something that keeps them more mobile, whether it's an extension on their oxygen tubing, whether we get a portable oxygen tank for them. But these are things that we need to look at when we're doing oxygen delivery. Low flow oxygen delivery systems. This consists of your nasal cannula and your face mask, your simple partial rebreather and non-rebreather. This does not provide enough flow to meet total oxygen and air volumes. Just kind of keep that in the back of your head as we move on. Okay, so nasal cannula. Nasal cannula has a flow rate of 1 to 6 liters per minute. If you're going to go higher than that, then you need to go to something else, but 1 to 6 liters per minute. The O2 concentration, or FiO2, for 1 to 6 is 24 to 44%. If you can remember that for every 1 liter of O2 that's increased, when someone's on oxygen, it increases the percentage of oxygen the patient breathes by about 3 to 4%. So remember, room air is 21%. So you would add that increase to that 21% per liter. So an example would be if someone is on 1 liter of oxygen per minute, that would be 3 to 4% plus the 21%. So you're looking at them breathing in anywhere from 24 to 25% oxygen when they're breathing in on 1 liter of oxygen. And the flow rate greater than 6 liters per minute does not increase oxygens on a nasal cannula. So anything greater than 6 liters, you're not going to increase that O2 past that 44%. If someone's on oxygen, again, you want to assess the patency of the nostrils, making sure that they're able to get oxygen through that nasal cannula. And you want to assess for changes in respiratory rate and depth. You also want to be looking at the prongs of the nasal cannula, making sure that they're not blocked, and making sure that they're not rubbing inside the nares and you're not having breakdown. There could be breakdown again around the ears, the cheeks where that oxygen tubing lays, and around the nose. If there is any kind of irritation, you can use a water-soluble jelly. And then also remind your patients that they need good mouth care whenever they're on oxygen as well. Okay, simple face masks. This simple face masks deliver oxygen up to 40 to 60% on 5 to 8 liters per minute. Masks fit securely over the nose and the mouth. However, moisture can build up under that mask, so you want to be removing it every 1 to 2 hours to do skin care and assessments, and also paying close attention to underneath those straps as well. You also want to be monitoring your patient who's on a simple face mask for risk for aspiration. And then also just be mindful that patients can become claustrophobic with that mask on. And then you want a secondary oxygen delivery system for when the patient eats. Partial rebreather masks, they provide 60 to 75% with flow rates of 6 to 11 liters per minute. Patient rebreathes about 1/3 of their exhaled tidal volume with each breath. You want to make sure that you adjust the flow rate to keep the reservoir bag 2/3 inflated.